Thank you, and hello everyone again. So in this talk, which is sponsored by Bristol Myers Squibb, I'll be going over some new data, I would say a decade-long data at max, regarding the role of ineffective erythropoiesis as the core or main pathophysiology in beta-thalassemia. Professor Tahar in the morning gave you a general overview of the disease as we know it today, the definitions, the clinical morbidity profile, but we'll dig deeper now together to look into why these patients develop such morbidities. This is a disclaimer from BMS, and these are my disclosures. So just to go back with a brief overview, I'm sure you've seen this slide presented in different ways today, but we have to start always the talk with it because it's very essential to understand the link between the thalassemia as a genetic disease with the actual pathophysiology. Beyond the talks that you will hear hopefully later about gene therapy and gene editing, everything else, especially for the new agents that you will hear about today, and also the luspatercept that I also presented in the morning, they go into the pathophysiology more than the actual genetic anomaly of the disease. So within beta thalassemia, we know that the alpha to beta globin chain imbalance is the main factor that determines the severity of the disease, and this leads to either ineffective erythropoiesis, inability to produce red cells within the bone marrow, or even for those few red cells that escape into the circulation, they die prematurely, and this is the case of hemolysis. Together, this leads to the state of chronic anemia in thalassemia. But why do we have such a very wide variation in disease presentation? All the phenotypes that we talked about today, whether we call them intermediate major or we call them NTDT, TDT, there has been many modifiers proposed. Probably the first one that is very known and conventional is the beta mutation severity itself. As we know, we determine severity by putting a label to the mutation itself as a beta 0, beta plus, or a beta plus plus, co-inheritance of alpha thalassemia, inheriting determinants that increase fetal hemoglobin production. So there has been a lot of aspects that have been uncovered over the past 10 years that can ameliorate this alpha to beta globin chain imbalance, and hence all the secondary outcomes of it, including ineffective erythropoiesis, can be milder or more severe, and hence we see the transfusion dependent or non-transfusion dependent patients. And this is data that we published actually this year at the beginning of it with a large group, including Professor Tahar and Professor Al-Bishlawi and many other colleagues from the region and from Italy. This was, if I'm not mistaken, around 2,000 patients out of a database of 8,000, so 2,000 patients with genotypes. And this was just to really revisit the link between the severity of beta mutations and a long-term outcome such as survival. And you can see here clearly in those graphs that we do obviously reaffirm the whole concept of the beta 0, beta 0 are the most severe forms, have the highest severity of ineffective erythropoiesis. But at the same time, we're also looking at patients with beta plus also mutation, especially ones that are prevalent in the region or in the GCC region, at least in the group that was there, like the IVS15 mutation. They almost have as worse survival as the beta 0 patients. So we're now recommending not only to look at beta 0 and non-beta 0, beta 0. Any mutation type can have a different or a varying level of severity. And this is the graph that also Professor Tahar shared initially from our recent review in the New England. And you see here ineffective erythropoiesis as the central of everything. And what I'll go over in the next few slides is what clinical data, what observational data do we have to link ineffective erythropoiesis to all of these underlying secondary pathophysiologies like hypercoagulability, anemia, and iron overload, and how these in turn are linked to clinical morbidity. So the main thing that we started with in this whole research journey to unfold or to uncover all of these pathophysiologic mechanisms obviously started with clinical observation. So initially, we wanted to understand what do these patients suffer from. It was starting to have initially clinical observations that Professor Tahar and Cappellini in specific had in their clinics, where we started seeing those variations in the morbidity profile between thalassemia major or intermediate or TDT and NTDT. So our thinking was that this underlying ineffective erythropoiesis, if left untreated without transfusion, it must be the one that is causing all these morbidities, for example, in those patients that do not receive transfusion, and hence will not, we need to understand how is that happening. And all of these morbidities were increasing in number or in incidence as patients advance in age, which gives more evidence towards the cumulative nature of whatever is going on in the patient's bodies, that if left untreated, it's accumulating over time, and eventually it's leading to, if you look at the table on the left, complications in almost every organ system: pulmonary hypertension, thrombosis, endocrinopathies, hepatic disease, and carcinoma. So every organ system is eventually affected. So we wanted to at least try to look at the effect of ineffective erythropoiesis directly, but as you know, this is almost near impossible, because otherwise you would need to biopsy every patient and look at some certain marker or degree of ineffective erythropoiesis in the bone marrow and link it to complications. So the next best thing we could do is look at some serum markers that are linked to the severity of ineffective erythropoiesis. At that time, at least that we did the study, it was GDF15, growth differentiation factor 15, which is known to be elevated in states of ineffective erythropoiesis, but also in some other diseases, in heart failure and colon cancer. And we found a very strong correlation, like the R of the correlation was a 0.8, which was a bit shocking, between the levels of this GDF15 and what we called at the time clinical severity score, which was mainly an addition of the number of complications that the patients had. And we wanted to also look at anemia itself, because that's the first, let's say, secondary outcome of ineffective erythropoiesis, that patients are anemic. So we wanted to look into anemia as a marker for increased morbidity, or as a causal agent, because anemia is obviously linked to chronic hypoxia. And is it, whether it's a marker for ineffective erythropoiesis or a causal agent itself, we wanted to see how it correlates or associates with morbidity. And this is the first study that looked into this. And in this study, the main thing that we came out with is that there is a correlation between low hemoglobin levels and morbidity. And we came out with what are becoming more and more gold standards for the thresholds of hemoglobin as a target. And the main threshold that came from the study is the hemoglobin of 10, whereby when we did the ROC analysis, like the analysis to see which level of hemoglobin predicts occurrence or lack of morbidity, the hemoglobin more than 10, all patients that had hemoglobin more than 10 did not have any morbidity. Patients who had less than 7 definitely had the morbidity, and between 7 and 10 it was a variable group. So at least we were able to send out the message to say, keeping the patients with a hemoglobin of 10 or more, whether by transfusion in TDT or by whatever means that are currently unavailable in TDT, hemoglobin needs to stay above 10. And recently we wanted to take this to a bit, I would say, a better observational study design. So to go from a cross-sectional study design, which was the first study, to look at things longitudinally. And in this study, we looked at patients over around 11 to 10 years to at least get survival estimates for 10 years. And it was very clear, as you can see here from the graphs, that morbidity-free survival was much shorter in patients who had a hemoglobin of less than 10 compared to more than 10, and as well in patients who had multiple morbidity, it was also the same. We wanted to also look in these patients, not only to look at the threshold and see which patients have a hemoglobin, let's say, of a low risk or a high risk. We were also looking at the change in hemoglobin, so the variability in hemoglobin. And we looked at, if you do a linear correlation analysis, you're by default looking at a change of 1 unit of gram per deciliter in hemoglobin. And there was a very strong correlation. So if patients had lower hemoglobin by 1 gram per deciliter, they had a higher risk of morbidity. If they had each 1 gram increase in hemoglobin, decreased the risk of morbidity by around 28%. And this is the probability curve that came out of this. Definitely ineffective erythropoiesis has immediate also, other than through the pathway of anemia, it also has a direct effect in many locations within the body. One of them is extramedullary hematopoiesis and medullary expansion. So the whole bone marrow environment is under a state of stress. that can lead to a medullary expansion, and that could lead to osteoporosis and some other bone deformities. But at the same time, there are many sites, as we know, in the body that have stem cell potential, that are trying to support the bone marrow to produce red cells that are deficient, although ineffectively, which leads to the formation of extramedullary hematopoiesis. The two most famous sites are the liver and the spleen, and that's why we see megalies in them. But at the same time, we can have any tissue in the body form these, what we call pseudotumors, which are balls or masses of EMH or extramedullary hematopoiesis. And when they're in certain sites like the the backbone, spinal canal, or in the pleura in the chest, they can cause significant morbidity if they grow in size to a certain extent. Leg ulcers are also very much into the pathophysiology of ineffective erythropoiesis, leading to the anemia and the state of chronic hypoxia. Probably we don't see them as much as in patients with sickle cell disease sometimes, but when they are present, they're very hard to treat and a challenge to the clinician. And I wouldn't dwell on this because we'll have Dr. Maya Bizri will go over the quality of life and psychological aspects of thalassemia in general. But then again, just to add one more morbidity to low hemoglobin levels, and that is mental health as a morbidity. The second thing that we looked at, beyond looking at the role of anemia as a consequence of ineffective erythropoiesis, is to look at the role of iron overload, primary iron overload. This was a bit puzzling to everyone in the beginning. I would say 15 years ago, we were looking at our patients with beta-thalassemia intermedia, and the question was, why would they load iron? They're not receiving any transfusion. Where is this iron coming from? There were various studies, and the theory keeps changing over time. So this is I think a figure I published around 10 years ago, but in the slides I keep changing it. This box on the right, the pink box, almost every presentation, because we keep hearing about markers involved in this pathway, but then there are other studies that show that they're not actually involved. But at least what we know that is happening is the following, is that the bone marrow in this state of stress is sending some sort of signal to the liver to decrease the production of the hormone hepcidin, which controls all the iron regulation in the body. And when hepcidin is low, what happens is that the body starts to absorb extra iron from the gut and to release more iron from the macrophages in the reticuloendothelial system. So you have a state of primary iron overload. And this state of primary iron overload is represented by mostly storage of iron in the liver and relatively lower serum ferritin level compared to what you would expect from a serum ferritin coming from transfusions. So at least the main marker that we know is involved in this pathway that stood the test of time in terms of many groups proving it is erythroferron, and now it is becoming also a target for novel therapies, but this is still in basic or animal studies. The next question we wanted to add is, okay, these patients are loading iron, so what? Is it as much of a big problem as it is in transfusional cases? And the answer was a large yes, because we were able to link iron overload in whatever marker we studied, whether it's serum ferritin or liver iron concentration or NTBI, non-transferrin bound iron. Any iron indices we studied, there was a link between iron and vascular disease like pulmonary hypertension and venous thrombosis through damages probably to the endothelium, endocrinopathies, osteoporosis, kidney disease, with some patients even reaching end-stage renal disease and requiring dialysis, hepatic fibrosis and carcinoma as well, and many, I would say, less common or less evident brain dysfunctional elements or silent strokes that were also linked to iron. One thing that was notable is that we found absence of iron in the hearts of these patients, and we still don't know actually the answer, but it's probably that the iron that is coming from the primary iron overload or the intestinal absorption is distributed in the body, mostly in the liver, rather than distributing also to the heart. And the three clinically meaningful studies or clinically practically meaningful studies that we conducted afterwards, one was to be able to understand which iron indices we should look at in this state of non-transfusional iron overload, because we cannot rely on the same threshold, the 1,000, the 2,500 And I recall in the morning there was a question about that as well. So the first thing that we found, and this is the graph on the left, is that for the same liver iron content in NTDT patients, you find lower serum ferritin level, just simply because of this mechanism of iron overload being different. So the study that we did after it is to link this threshold, or to try to identify the threshold that is linked with morbidity, and that's where the 800 came from, that patients with a serum ferritin above 800 do suffer consequences of iron overload in terms of hepatic and endocrine and vascular morbidity. So this became the recommendation to provide iron chelation to these patients above 800 compared to the 1000 in TDT patients. And for the same thing for LIC, we identified the threshold of 5, so an LIC of 5 and above was linked to an increased morbidity burden in these patients, and translated into being the threshold we recommend iron chelation for these patients in the guidelines. This study, which is actually also the newest, we also did it with this international working group database that had around 2,000 plus patients with thalassemia. And Professor Bishlawi kindly also shared her data with us. And we published this trying to look into how do we look at anemia and iron overload combined. And you see the very sadly synergistic bad effect in both. So when you see that patients who had anemia fared worse than those who didn't, and patients who had iron overload had a worse survival than those who did, and patients who had both anemia and iron overload did the worst compared to having one alone. So this was again a message that we need to look at both factors almost equally. You already had the presentation by Professor Cappellini about thrombosis earlier, but this is again just to also put ineffective erythropoiesis at the core of the hypercoagulable state that these patients suffer from. This figure that you see on the right is explaining what is happening in those patients in terms of the red cells that are coming as an outcome of ineffective erythropoiesis, hemolyze prematurely. There is a phosphatidylserine exposure on their surface, and this makes them themselves thrombogenic, so the red cells are the ones that are actually triggering the thrombotic events rather than platelets per se. But obviously there are, and this is the summary figure on the left, there are multiple factors that are involved that lead to eventually to the hypercoagulable state in these patients. And this is one of the largest studies done to date by Professor Taher that looked into the clinical burden of thrombosis, showing how in patients who did not receive transfusions, splenectomized patients, and the ones who had conventional risk factors had a high rate of thrombosis compared to others. This is also again linking silent cerebral infarction that we see in beta-thalassemia to both transfusion receipt and to hemoglobin level. And we even did this three-dimensional plot to look into the impact of both iron overload and hemoglobin level on the development of stenosis on MRA of a small group of patients. And you see, we call it a blanket graph. Do you see that these, again, two factors play in disadvantageous harmony? So when the NTBI, which is the non-transferrin bound iron, was higher, or the hemoglobin was lower, we ended up having more stenotic events in these patients, which led to consequent infarcts later on. And this is the thalassemia thrombosis risk scoring system that we put together not long ago, 2 years ago, myself and Professor Taher and Professor Cappellini, to try to at least put all this information together. And you see clearly that hemoglobin and iron are at the center of this. The main two consequences of ineffective erythropoiesis are at the center of this risk score, being culprits in the hypercoagulable state. The last morbidity to look into as an effect of ineffective erythropoiesis, which is also on the spectrum of hypercoagulability, is pulmonary hypertension. Pulmonary hypertension has always been a subject of debate, very, very vicious debate sometimes at the ASH Congress between different theories of why is pulmonary hypertension developing in sickle cell disease? Is it the nitric oxide pathway? Is it some other pathway? Is it the sickling pathway? In thalassemia, we believe it's a much more straightforward story. It's hypercoagulability. We believe that it's thrombotic events in the microvessels of the pulmonary vasculature that are leading to this backflow of pressure backwards to lead to a state of pulmonary hypertension. And we've done a study around 10 years ago now to look into the risk and catheter-defined risk of pulmonary hypertension. As you would expect, it's much lower than those defined by echo. If you look at echo, you find studies reporting pulmonary hypertension rate in the 10, 20, and 30% even. But the true prevalence, if we look at studies that used right heart catheterization, the level is around 2%, which with a higher level in non-transfused patients. And we recently published a follow-up on this 10 years later to look into mortality in those patients that develop pulmonary hypertension. And you can see that it is high. Around 40% of patients who had pulmonary hypertension died within 9 years, despite use of various agents to try to address the pulmonary hypertension. So on the graph on the right, you see that definitely patients who had dual agent therapy did better than those who had single agent therapy, than those who had no therapy at all for pulmonary hypertension. But still, we don't have currently clear guidelines on which agents to use. And this is still, there's a nice editorial on this paper written by Professor John Wood that calls this a very clear unmet need, that pulmonary hypertension still doesn't have a solution in thalassemia. And definitely, to close with what ineffective erythropoiesis is doing and what happens when you give patients transfusion therapy. When you give transfusion, you're simply reversing the effect of ineffective erythropoiesis. And you obviously open up the door for a new morbidity, which is secondary iron overload that is caused by the transfusions themselves. And that's why the main management landscape in patients with TDT today is focusing on preserving this transfusion or replacing it with any alternate. But in those patients that have severe ineffective erythropoiesis, you have to address the underlying pathophysiology in this way. The problem in non-transfusion dependent patients is that this is not the case. As Dr. Tahir said in the morning, we could give these patients transfusion to address the ineffective erythropoiesis, but maybe we should think of some other alternates. Obviously, transfusion is the only solution until we have something that is available for these patients. But at the moment, most of them that have the hemoglobin of less than 10, the danger risk level, are either being given transfusion if they have certain complications, or are coming into clinical trials for novel therapies addressing anemia in these patients. And this is also from a recent publication we had with this large database that we had in Italy, and also with collaboration from Egypt, where we saw that the patients that received regular transfusion actually did survive better. So for those patients that had anemia and did receive transfusion, they did fare better. So definitely there is a role in transfusion in these patients until we have more novel therapies that you will hear about today that will be replacing the need for transfusion therapy or decreasing transfusion therapy in TDT. And the same for iron chelation therapy in these patients. We already have survival data that shows that chelation therapy also did its job in terms of improving their survival.